Very good evening, everyone, and thanks for accepting the invitation, RJK sir, Ravikiran sir, as well as Dr. Nitin. So we are here today to discuss about the guidelines and the critical appraisal of different guidelines for management of HIV available. So let me introduce myself first. I'm Dr. Praveen. I'm a consultant infectious disease working in AIG hospitals, along with my colleague Dr. Haripriya, who will be presenting the case. So what we are going to do is we are going to do a case-based discussion along with the different challenges in managing the HIV positive patients in that cases we have included. So it's a hypothetical case. So when the case keeps on going, we'll see some of the issues and problems the patient will be facing. So Haripriya, doctor, can you share the screen now? So let me introduce the panelists. Hello.
Sorry, I don't have the control on this. Yeah.
So we have Dr. RJK, Dr. Gopalakrishnan sir with us. So he has done his graduation from Madras Medical College, followed by internal medicine in PGI Chandigarh, followed by his American board certified both in infectious disease as well as in medicine. Right now, he's working as a senior consultant in Apollo hospitals. He has more than 60 publications, various journals, and he has written many books as well. So we all used to wait for his lecture when we are going to attend SITSCOM. So the thing about RGK sir is, like, besides the studies, the evidence, he also used the logic to put that evidence into a single patient. So we always enjoyed attending his lectures, and today we are very happy that he accepted our invitation just over a phone call to attend this webinar. And the second panelist we have is Dr. Ravikiran Barigala. Sir is working as a senior consultant of infectious disease in Apollo hospitals here in Hyderabad. So he's a perfect gentleman because he's the first one I met here after coming to Hyderabad recently. Very soft-spoken, very knowledgeable. He has done his MD medicine and has infectious disease from USA, and then he's working here in Apollo hospital for some time now. And he has done his publications. There is a lot of research interest. He's done many publications across the journals. And one of his area of interest is definitely, like any other ID physicians, is HIV. So we are happy to have you, sir, here. And our third panelist is Dr. Nitin Gupta. He is my senior in AIMS New Delhi when I was there, and he's also a friend. And he's a very honest person to be. Like you people, we may see many sincere people, but he's one of the honest guys. And he is like a printing machine. He has more than 120 publications, and he's also editor for 4 international journals. One of them is the famous QZM. And he's been part of writing many books, and now he's here with us. And his areas of interest are tropical fevers, HIV, and I think the recent interest is antibiotic stewardship and infection control is his recent interest, it looks like. Okay, so without wasting much time, I will ask Dr. Haripriya to go through the hypothetical case which we made, where we are going to discuss about different challenges which we face and what are the guidelines says and what are the controversies in the guidelines. Over to you, Haripriya.
Thank you. Are the slides visible to the audience?
Yes, ma'am. Please make it a presentation mode.
It is in the presentation mode, actually.
Can you please reshare? Stop share and reshare, please.
Is it okay now?
Yes, it is.
Okay, let us start with this case. So this is a young male, 32 years of age, from West Bengal with no known comorbidities, presented with fever, weight loss, and diarrhea of 2 months duration. His BMI is 32, and he's tested positive for HIV-1. On evaluation, he had a CD4 of 35, VDRL negative, cryptococcal antigen negative. Fundus examination was normal. Hepatitis B and C serologies were negative. Chest X-ray was normal. LFTs, RFTs are in normal limits. He's married, and his wife is pregnant with 24 weeks of gestation.
Yeah. So let us start with Dr. RJK here. Sir, can you dissect this case for us? Like, this is a garden variety of case we see in OPD. So can you please go through everything and dissect this case for us?
Yeah, so when somebody presents to you with HIV, the first principle is you sort out the opportunistic infection side of things first before dealing with the HIV. So this is basically a patient who has fever, weight loss, and chronic diarrhea with a CD4 count of 35. So there is a chance that this may be a GI pathogen with constitutional symptoms as well. So you would have to factor in the CD4 count there as well. So some of the differential diagnoses you would think of would be, in addition to GI coccidian parasites like Cryptosporidium, Cyclospora, Isospora, etc., those that cause systemic involvement as well. Tuberculosis, Mycobacterium avium, disseminated histoplasmosis, disseminated CMV disease as well. So these are some of the things that run through your mind with this CD4 count. And so don't worry about the HIV right now, that can wait. So you need to investigate along these lines first.
Okay, sir. Thank you. Dr. Nitin, so basically you are also from West Bengal. So can you tell us what is that specific about West Bengal if someone is with a CD435 and coming from West Bengal? Will your differentials will be different, or do you want to screen for something?
Did we lose Dr. Nitin?
Sir, your voice is not audible. Okay, sir. No, sir, no. So we'll come back to you, sir. In between, Ravikiran, sir, recently I was listening to one of your lecture on metabolic syndrome. So this male, after losing so much of weight, his BMI is 32. So what is it like having a BMI of 32 with the retropositive state? What will you be thinking in the background?
First, I'm thinking that he was obese to begin with. If he's now 32, what was he before? And he's 32 years of age. So I'm always thinking about, okay, if he was 35 or more than 35, right, then he's really in the obese category. If that any associated health conditions are there, diabetes is coexistent, cholesterol or thyroid, other things are coexisting, which are non-infectious, but we see a lot more of those things in HIV, and especially in overweight patients, obese patients. For some reasons, nothing bad about Bengal patients, but what I know about Bengal is they eat a lot more sugary diets, a lot more oil-based diets, so their fats and cholesterols and sugars tend to be higher in that area. It is not an infectious thing; it's more of a lifestyle thing.
Nitin, sir?
Nitin can probably add about the dietary things much better. But
am I audible?
Yes, sir, you are audible. Yeah.
Thank you. Sorry for this technical problem. So what I was saying was that, this presentation could very well be a stage 3 HIV, just based on the clinical presentation. But when we talk about opportunity infections, there could be a list of things. But if we talk specifically about West Bengal, maybe VL could be a possibility. I don't see CBC here. I don't know whether there's a pancytopenia or not on physical, whether there was any splenomegaly or not. But this could be one of the things. Second, it's not specific to West Bengal, but a lot of cases are diagnosed for West Bengal is myeloid. Again, these patients sometimes have non-specific without any localizations that they can present. This is beyond the usual list of pathogens that could be possible here.
Okay, sir. So I'm going back to VRK, sir, again. Sir, could it be just HIV enteropathy, which will, like, what is HIV enteropathy? Can it present like this chronic diarrhea, weight loss? Or is there anything specific to say that this is not opportunistic infection, this is HIV enteropathy?
Sorry, who's the question for?
Sir, RGK, sir, you.
For myself, okay.
Yeah.
So, so HIV enteropathy is by definition a diagnosis of exclusion. I certainly wouldn't think of it in any patient with fever. And it is very risky to diagnose that particular entity in a country which sees so much of opportunistic infections. So I would just take that off the list right now. Common things are common. If you want to approach it from a commonality standpoint, what causes fever and weight loss in India? Typically, it is TB. If you put in the diarrhea part of it, you would have to think of MAC, histoplasmosis, etc. So this patient would need investigation, would need blood cultures, would need imaging, preferably a CT scan, abdomen, perhaps with the chest included as well, and take it from there.
Haripriya, can you go back into the previous slide? Yeah. So this is for Dr. Nitin. So what about like having a false positive HIV serology? How common it is, and where we can probably see a false positive serology as well?
with the current set of diagnostic principles that we have, usually we go for a set of 3 tests where, they are either of different principles or of different antigen. It's very, very unlikely to see a false positive HIV in a clinically compatible scenario. So in such a patient, probably the likelihood of false positive serology would be very, very less.
Okay, sir. This is to Dr. Ravikiran, sir, again. Sir, I think there is already a question. So why the cryptococcal antigen is done? Is it required for all the HIV patients, or do you want to see CD4 and do it?
Cryptococcal antigen is part of the full spectrum of tests done for any newly diagnosed HIV patient. It is a good thing to do, but especially I think it's much more important for patients whose CD4 counts are lower, especially lower than 200 or lower than 100. This patient's CD4 is really low, 35. So definitely at a very, very high risk. So I would definitely do a serum crag for this patient. And I think that's very important. I'll just go back one point about the fever and diarrhea. In HIV patients, we generally like one thing to explain everything. But in HIV patients, it is not necessarily. They could have 2, 3, 4 things going on at the same time. Like a fever could be because of TB, but diarrhea could be something else. Okay, some cryptosporidium or something which is causing diarrhea. Cryptosporidium shouldn't cause fever. Fever could be something else. So we should always, just because we find something doesn't mean that that is the only thing that explains everything. We have to do a lot more thorough job in ruling out other causes also, especially in HIV, severely immunocompromised.
Okay, sir. Sir, here, like in our national guidelines, they say if your CBC, LFT, RFT, along with chest X-ray is normal, you go to start with ART. So do you think that chest X-ray itself can exclude a possible active tuberculosis? How sensitive it is? How many cases we can just miss just because we are doing chest X-ray? You want to add on something like? This question is to RG cases, sir.
Yeah, so the first thing is guidelines are written for programmatic management. This is not for the management of individual patients. If you want me to quote the evidence base, there was a paper in the New England Journal about 10, 12 years ago, which showed that the constellation of fever, weight loss, and night sweats was 95% accurate in picking up tuberculosis in the HIV positive setting. So it is an absolute error to start antiretroviral therapy till you have ruled out all opportunistic infections. So you need to investigate. And when you're sure there's nothing going on, then introduce ART. If you start ART without an adequate workup for opportunistic infections, you are risking iris. And this is called unmasking iris by definition, which is always a headache to sort out. Because if you don't know what you're treating, if it's an unmasking iris, you don't know whether it's disease progression. You don't know if it's unmasking iris. You don't know if it's drug-resistant disease. It's just a mess. So this is a common error in practice, treating the HIV just because the HIV is there. You need to sort out the opportunistic infections with whatever cost-effective tests that you can do. A CT scan in this patient is a must, a CT abdomen, especially because that's where all the localization is. Perhaps endoscopies would be needed, but certainly stool exams, CTs would be the way to start off.
Okay, sir.
So we have answered most of these. So other investigations have mentioned like CT chest, CT abdomen, stool examination. So any other investigations that are not discussed? Anyone would like to add, sir?
Just to add this one thing about CT. So when we talk about CT chest or CT abdomen, it also has to do with in general, if for any patient I'm talking about, not specifically for this patient, when we talk about these things, we have to also see about the availability of these things when we are treating such patients in low resource settings, in primary healthcare centers. There are ART centers everywhere in the country. One of the study that we did with median time to initiation of ART from registration in one of the tertiary care hospitals in India, and we saw that from 2005 to 2014, the median time to initiation of ART increased from 7 to 21 days. And so, a lot of times these might be not necessary, not specifically for this case. So we should use investigation. So in a hospital where CT can be done on day one, it's good enough. But if a patient has to wait for 14 days or 21 days for a CT scan, that might be a little difficult.
So yeah, just let me just add to that. I know that in many resource constrained settings, we can't do CTs, but it's an absolute error to start the ART at this point. So in this setting, if I have a patient who can't afford therapy, I would often give an empiric trial of therapy for my top 4 or 5 pathogens, perhaps an empiric trial of nitrous oxide, perhaps an empiric trial of antituberculous therapy with or without MAC coverage. Starting ART in a patient who's losing weight and who's having fever would be a major clinical error. Either you investigate or you do a reasonable clinical trial based upon your top diagnosis.
So this is like kind of very interesting, because most of the HIV patients, they do present with some of the constitutional symptoms with or without opportunistic infection. And our national guidelines says that we have to start INS therapy for all the patients once you do a chest X-ray. So what is your take on that, sir? Like, are we, because we do miss some of the cases without just with a chest X-ray, and we are asking everyone to get, irrespective of MONTU or IGRA, to give INS for all the patients.
Yeah, so that again is a gross poor clinical medicine. In a patient who presents with a syndrome, with fever and weight loss, you diagnose the syndrome. By definition, that cannot be latent TB. By definition, it has to be active TB or it's something else. So you investigate the patient. If you truly believe that the patient has TB and you can't confirm it, you give a trial of 4-drug ADT. Giving INH monotherapy at this point is a gross clinical error, and it would indicate very poor, clinical practice. Forget about guidelines. Guidelines are for guidelines. You are treating a patient in front of you with weight loss and fever. So either you investigate or you give an educated trial of an appropriate opportunistic infection. Okay, so we'll move forward.
So these are some evaluations which the NACO 2021 guidelines recommend. So apart from regular tests, they also recommend based on endemicity to look for leishmaniasis. So in this particular case, would you, from patient being West Bengal, is this recommended? Nitin sir?
Sorry, I didn't get the question.
So they, based on the endemicity, they recommend to rule out leishmaniasis. So this particular patient we are discussing from West Bengal, would you like to look for leishmaniasis?
Yes, absolutely. So, so although we need to, do a good physical examination, see whether spleen is there or not, whether there is pancytopenia there or not, or any other features, but sometimes asymptomatic architectural positivity is also there for patients with visceral leishmaniasis. And we know that the treatment for visceral leishmaniasis in HIV patient is different from what we usually do. So in a normal visceral leishmaniasis patient, we can try with a 10 mg per kg liposomal amphotericin B single dose, but for HIV patients, we usually go for a combination therapy and liposomal amphotericin B over a period of, let's say, one of the regimen is 11 days. So yeah, probably architectural would be a good idea.
Yeah. Okay.
So for the completion's sake, this patient had a infection with cryptosporidium and that was successfully treated. Okay. So now we can move forward, Haripriya. Yeah.
So this is
the question, like, do we really want to get a baseline viral load for all the patients who are newly diagnosed with HIV? If you want to do it, why? What is the advantage or requirement of doing a baseline viral load? This is for Dr. Ravikiran, sir.
Yeah, definitely. I would get a baseline viral load for all of my patients. That's been done routinely in almost all countries. All guidelines, Western guidelines, really recommend doing a baseline viral load. It helps in many ways. First of all, you get an idea of what are you really dealing with. Okay, what is the count of CD4s? Is it really high? Is it low? Is it some medications we don't really give if the viral load is too high? And then we're also looking for the response. We're not just looking at a CD4 response. We're looking at a viral load. How much has it fallen? We expect, the viral load to become undetectable by 3 to 6 months. Most of the regimens, dolutegravir-based regimens that we use these days, by 3 months, we should really have it undetectable. And but it is relative also. Like sometimes if the count was in millions, and then it's come down to maybe like 10,000, that is still a decent response. So you need to have, that is why you need to have a relative number. Like What was it before? What is it now? And that's why I would routinely do it. I think the guidelines need to change on that. Guidelines, the government guidelines, we're not here to pick on the government. They are trying to do the best job that they can. In the past, they didn't even do viral loads for anybody unless they completely failed. But now they're changing, they're starting to do it. And I think this might also come by in the future. What they're trying to do is for a large masses of people. But I think it is a good practice to have a baseline viral load. Can we live without it? Of course we can. In resource constraints, we can work without a viral load, but it would be better to have it, in my opinion.
Sir, again, like you said that based on the viral load, like if viral load is high, I will try to avoid some of the drugs. So what are the drugs which should not be used with a very high viral load?
So with some of the high viral loads, some drugs may not work very well. Some of the, like Reltegravir has the problems. There will be problems even with efavirenz with more than 100,000. Generally 100,000 and up, there's been problems. Having said that, I have used it in many of those cases. I have not really found many problems, although in some cases I have. Efavirenz, I've had problems. Definitely Reltegravir, I have problems. Dolutegravir, I have not had too much of a problems even with a high viral load.
So now that we are discussing a little bit of drugs, I want to move a little laterally. So I would like to ask Dr. Nitin regarding what are the antiretroviral drugs which are available, the classes grossly, and what are the drugs available in each class?
Okay. Yeah, before I start, just one point on this baseline viral load thing is because most of the guidelines recommend baseline viral load, but why NACO is not recommending or is not recommending baseline viral load as yet is probably one of the explanation could be because the first drug that they are recommending is tenofovir, lamivudine, and dolutegravir, and this combination is good with any viral load. And seeing that that response with integrase inhibitor, especially dolutegravir, is very good. Viral load reduces by baseline, by detectable level in as early as 1 month to, let's say, 3 months. And the first viral load that NACO recommends is at 6 months. So by that time, if the patient does not have an undetectable viral load, this might signify there is something going wrong. This being said, that I agree that baseline viral load should be done. With regards to the antiretroviral drugs that we have, so the ones that are there in India primarily, so initially we have the NRTI. Most of the ART regimens are based on a backbone of NRTI. So the first NRTI that you usually use is from TDF, TAF, ABC, or zidovudine. So the preferred one is TAF in most guidelines, but in Indian guidelines, TAF is still not available. So TDF is the one that we routinely use in the when we go by Indian guideline. ABC is an alternate, abacavir is an alternate option, but again, it has some issues with cardiovascular comorbidities, and it's not recommended, especially in high viral load more than 5 lakhs. Zidovudine is something that is not recommended, but there may be some question on whether when second line ART is switched, so you might change tenofovir to zidovudine. The second drug that we usually use is again NRTI based drug. That what we use is lamivudine or emtricitabine. The guidelines recommend lamivudine. Emtricitabine and lamivudine clinically does not make there's not a lot of difference. Theoretically, in vitro potency with emtricitabine may be a little higher, but lamivudine is good enough. So either of these drugs can be used. And the third drug is usually either an NNRTI or a protease inhibitor or integrase inhibitor. So the NNRTI that is available in India is efavirenz and nevirapine. So nevirapine in most situations is not supposed to be used even now in Indian setting as well. So efavirenz is the NNRTI that we commonly use. Rilpivirine is supposed to be better, lesser side effects, but it's not supposed to be used more than 1 lakh, and it's not available in India as far as my knowledge is there. Second, we go for protease inhibitors. The 3 most common protease inhibitors that we have are atazanavir, boosted atazanavir, we have lopinavir and darunavir. Again, darunavir is the most preferred one, but in Indian guidelines, darunavir is mostly in the third line ART. Atazanavir is the one that is preferred. Lopinavir has issue primarily with pill count and some side effects. And the third group of drug is integrase inhibitors, which are primarily the preferred third line agent, the third agent in the first line ART. So the ones that are commonly available, there are 4: dolutegravir, bictegravir, raltegravir, and elbithygravir, publicistat. Elbithygravir has a problem that, again, because it requires more boosting, there are issues with drug interaction. Raltegravir is the one that we have most experience with, but the barrier to resistance is lower. So the preferred integrase inhibitors are dolutegravir or bictegravir. The body of experience with dolutegravir is more.
Thank you, sir, for summarizing it very nicely. So I would like to ask the same question to RJK, sir. Sir, will in this particular patient, whether this baseline viral load will change the regimen you use? Will it be different if the viral load is different?
No, the viral load will not affect my antiretroviral regimen, but it will affect what happens when I follow up the patient. If the patient is not virologically responding, in my practice, I always check viral loads at 4 weeks, but definitely it's compulsory to check a viral load at 6 months if you don't do it before that. So the purpose of the viral load is to have a baseline to compare and obtain a virological response. You're always looking for at least 1 log drop on the 4-week testing. Remember, we don't do baseline resistance testing in India for cost reasons. I agree that in the era of INSTIs, baseline virological resistance testing is not necessary in the majority of patients, and I don't do it in my practice either. But I would surely insist on a baseline viral load before I start therapy.
Thank you. We can move forward, Haripriya.
So for NACO or WHO doesn't recommend baseline viral loads, only the DHHS recommends an entry into care HIV viral load. So we have already discussed most of this opportunistic therapy and ART. So in this, I would like to ask the panelist. So if when we are considering particular OA, let's say this patient supposing having histoplasma or toxoplasma, when is the after how long of treating OA would you like to start ART? Ravi sir.
So we don't really see those much at all. Okay, very, very few cases that we first of all see. I don't know why they put it in the guidelines, but it is pretty rare. Even in that area of India, we don't see it as many cases. Especially penicillosis, telleromyces, we don't really see that as much, but maybe that is there. I don't know. So first, if we have any of those infections, first we test for those, treat for those, and then wait. When do we actually start it? You kind of underline some of those things, but at least a month or two probably, and then we would start ART. We would not start immediately. That would be the bad thing. Or starting ART first, like Dr. RGK just mentioned. That would be the worst thing that you could do for the patient. That's pretty much, that's one of the worst medicines that you could do. Or starting both at the same time. That's also bad. First, treat it, see how the patients are improving. And then once they are better, then you start them on the ART medicines. So that might take at least a month or two in my opinion.
Okay. Sir, Dr. Nitin, this is for you. The problem of iris is more significant with meningeal diseases like cryptococcal meningitis and TB meningitis. So for the meningitis cases, what is the gap you do after starting ATT or liposomal AMPHO after treating? How many days you will start consider ART?
So the cryptococcal meningitis evidence came from the cryptococcal optimal ART timing trial, the CODE trial, where they randomized patients who were treated early and the other half was treated late, and the mortality was higher in the early arm, presumably due to cryptococcal iris. The median week of duration in that trial was around 5 weeks. So minimum of 5 weeks, maybe longer depending upon initial response. For TB meningitis, again, we extrapolate predominantly from the CODE trial data, and for TB meningitis, we tend to start a little later. Again, guidelines say after 4 weeks, but the data for Cryptococcus is more robust. For other OIs, mostly, again, the data comes from the Camellia trial, where it was predominantly for TB, and where they saw that starting a treatment, ART after initiation of ATT, within 2 weeks has actually lesser mortality than starting after 2 weeks. So for most other OIs where CNS is not involved, it is probably preferable. It's preferable to start ART earlier, preferably within 2 weeks. For this toxoplasmosis, I see here that in the national guidelines they have written to start ART after 6 weeks of treatment. I'm not sure where this data has come from, because mostly for toxoplasmosis, treatment response is faster, is more clinical response is faster, radiological response is also good. So waiting for 6 weeks after treatment of toxoplasmosis is something that is probably not mirrored in other guidelines, but I don't know what is the reason behind this recommendation.
Okay. Sir, RJK sir, so what do you do if the case is CNS toxoplasmosis? Do you wait for 6 weeks, or you see the response after 2 weeks, you start on ART?
Yeah, so that depends upon whether they have manifestations of raised ICT. If somebody presents to me with multiple ICSOLs, you confirm toxo or you strongly suspect they have a lot of brain edema, I would wait a little bit longer. The whole issue is for a CNS OI, you trigger off iris within the brain, within a closed compartment, whether it's Cryptococcus, TB, or toxo. So whereas if there's just a single lesion without much brain edema, I might start ART within 2 weeks. See, all these patients require early ART. By definition, they have low CD4 counts, and the Camellia trial was alluded to earlier for TB. But you have to balance that versus the risk of coning when you start them on therapy. So 2 weeks, 4 weeks, So the greater the raised ICT, the longer you wait.
Sir, will it depend upon the CD4 count the patient have? Because the difference that is seen in Camellia trial is when the patients had CD4 less than 50, if you start ART, there is more benefit. But otherwise, 2 weeks versus 4 weeks is not bad. So
so the current guidelines, WHO guidelines have been updated. All patients with TB should get ART within 2 weeks. So that is what I think your NACO guidelines also reflect. So for TB, it's well worked out. Unless you have TB meningitis, when you postpone it out, again, that's a closed compartment syndrome. For the other opportunistic infections, barring cryptococcosis, in general, you can start early because these are not closed compartment iris syndrome. So in general, I would tend to start within 2 weeks for all other opportunistic infections.
Okay. So one more thing which we always try to difficult to take a call. So after the CryptoTech study, people started saying that steroids should not be given in cryptococcal meningitis, that is shown to be increasing mortality. But sometimes you diagnose the case of cryptococcal meningitis as a part of unmasking iris directly after 4 weeks ART. So at that time, do you use steroids to deal with the cryptococcal meningitis unmasking iris, or you avoid?
Personally, I have never used steroids for any of my cryptococcus patients. If they have problems with raised ICT, you tap them. You keep tapping them, you put in a lumbar drain, you drain the CSF out mechanically.
Okay, sir. Ravikiran, sir, do you use prophylactic steroids to decrease the risk of iris in HIV patients with very low CD4 diagnosed with tuberculosis and HIV?
No. Prophylactic steroids are a really bad idea. Really don't do that. You're already immunocompromised. You're adding another immunocompromising agent. I wouldn't do that as a prophylactic therapy. The only times that steroids would be used is some of the iris cases, not for cryptovirus. I would, just like RGK sir said, I wouldn't do it for cryptovirus. But for TB iris, yes, we could use that, but not for other cases.
Okay. Dr. Nitin, what is your practice like? Do you do the same or do something?
I think you're alluding to the PredMed trial that got published in NEJM, I think 2018 or 19. So the idea, I feel, was a good idea, but we suffer more with iris in patients with CNS manifestations. Other iris are more manageable. So, but that PredMed trial did not include a lot of CNS patients. So, at least I have not, the paper was sound, and the requirement of higher dose of steroids when patients developed iris was not as much if you give low dose steroids in that paper. But personally, I've not been, able to start this low dose steroids as yet in my patients.
Okay, sir. Yeah, Haripriya, we can move forward.
So when to start ART,
So-
I think we have addressed that. So
Move forward. We have discussed this also, right? So what are the antimicrobial prophylaxis with a CD4 of 35? Ravikiran sir, can you summarize this for us?
The main things that we're really trying to prevent is PCP, MAC, Toxo. So what we would do for PCP and Toxo, we're going to use Bactrim 1 tablet double strength once a day. That is the most commonly used. There are other ones also, but that would be the most commonly used. And for MAC, it is azithromycin, 1200 milligrams once a week is used for prevention. Although that is not used as commonly, I have stopped using that because I really don't see much of a MAC in my practice at all. So I have given up on MAC prophylaxis. I still use Bactrim prophylaxis for my patients.
Okay, sir. What about the fluconazole for CD4 of less than 100, where you don't have the facility or patient is not able to afford for the cryptococcal antigen?
I don't empirically put them on fluconazole. Our rates of cryptococcal infections are also low, even among our HIV patients, even with low CD4. So I don't routinely do it. I check them for a crack, and if it is positive, I do it, even whether they have symptoms or not. Of course, if they have symptoms, I'll do a lot more evaluation, give them full doses. But I don't prophylaxisly just put them on medications if I do not have crack availability.
Okay, sir. RJK, sir, what are the challenges of diagnosing and treating latent tuberculosis in a retropositive patient?
Well, let me tell you, it's a big diagnostic challenge. And if you're in doubt, don't offer latent TB treatment to these patients. In a TB endemic country, in patients with low CD4 counts, it is almost impossible to exclude active TB, especially when they have symptoms. If the patient is totally asymptomatic, that's fine. But every patient with a low CD4 count has some fever, some weight loss. Even if you scan them from top to bottom, do all the tests which high resource settings allow, you can't sometimes rule out TB. So latent tuberculosis treatment is something which is right on the back burner in a TB endemic country. I know the guidelines, including WHO guidelines, put that as among the top 4 indications for prophylaxis. But if you jump into LTBI treatment right in the beginning, you can actually trigger off isoniazid resistant TB. Your patient will come back. And I've seen this a couple of times in patients who got LTBI treatment. They came back with culture proven isoniazid resistant TB. So that's not something which I'm very keen about. In fact, in my practice, what I do is I consider latent TB treatment 6 months into ART. When my patient is doing well, they've gained weight, they're virologically suppressed. At that point, I'm confident we are not dealing with active TB. And at that point, I might consider an intervention for latent TB.
Okay. I think we can move forward, Haripriya. Yeah. So what about vaccination, sir? Dr. Nitin, will you consider for any vaccination at this point of time, or do you want to wait till CD4 is a little bit better?
Yeah, so anyways, no live vaccines are, you should not give any live vaccines if below a CD4 of less than 200. And kill vaccines also have a poor response, especially with this immunosuppression. So probably at this point of time, it's not, beyond the usual, probably influenza vaccination, kill influenza vaccination, annual kill influenza vaccination should be okay. But for others, probably it would be a good idea to wait till there is a little better immune recovery.
Okay, sir, thank you.
So our patient is started on TLD, and so we have discussed this. NACO and WHO recommend all patients to get the isoniazid prophylaxis, whereas DHHS asks to treat latent TB after testing. So moving forward, this, as we discussed in the first slide, this patient is married and his wife is pregnant with 24 weeks of gestation. On testing, his wife is also HIV positive. So how do we do about this? How do we go about this? How do we investigate her, and when do you want to start her treating, and with what? Ravi sir?
So we have to do pretty much the same testings that we just talked about, the routine testing for any newly diagnosed HIV. We have to do pretty much the same thing. Pretty much everything is the same. Okay. Whether you have symptoms or not, the baseline evaluations are the same. If you have any symptoms, you try to focus more on those symptoms and try to rule out any active, whatever the active infections are, you rule it out. In this patient, the wife was incidentally detected. So I am assuming that she does not have any symptoms, but she's pregnant lady. So whether she's pregnant or not, the guidelines really, recommend immediate ART. So we would try to get the baseline labs for her and then start her on medications. What regimens do we want to start? The preferred regimens right now, at least in the public sector, is the same regimen what you used already, is the TLD regimen. Earlier, it used to be the TLE regimen, the efavirenz-based regimens. Now they've changed it to TLD, the dolutegravir-based regimens. There were some concerns earlier with dolutegravir, with neural tube defects, birth defects. But as we have seen from the African studies, it has really not shown that is necessarily true. And we have used it, and I use it in my pregnant ladies now, and it's good. And we start using it, the sooner the better. Some have suggested maybe not to use in the first trimester, but I think those concerns are a little overblown. Probably, I think it's fine even in the first trimester. And the sooner we start it, better. The passing to the babies is much less the sooner you start it.
So, Dr. Nitin, for example, this patient was again started on dolutegravir-based regimen, but by the end of the EDD, she is not able to clear the virus. For example, there is still some HIV copies in her blood. So, what are you going to do in such a situation?
So the thing is that this seems to be like an hypothetical scenario, because transmitted drug resistance to integrase inhibitor is not very high, and dolutegravir has excellent potency. So we are looking to suppress viral load by week 37, and I think most dolutegravir based regimen should be able to suppress by 37. So this is one of the cases where frequent viral load testing would be very, very valuable. So before anything, this is one of the patients where you should start ART as early as possible, possibly on the same day, and then frequent viral load testing to see whether viral load suppression has been attained. If in these frequent visits you're not able to show that viral load is not suppressed, probably adherence might be an issue, and or drug-drug interactions are an issue here. So those would be my area of focus, because as such in a treatment naive patient, baseline INSTI resistance is something that I will not be worried about.
Okay, so we'll come back to that again. So we can move forward right now.
So this is what NACO 2021 guidelines say for all women, not only pregnant, for all women of childbearing potential who do not wish to take DTG based ART after adequate and optimal counseling. They have given options. So how do we go about this? Is what guidelines is. So RGK sir, do you usually explain the patients about different options in the current day, explaining DTG and efavirenz and giving the option? Do you do that?
No, NACO guidelines are already outdated. There is just a recent randomized control trial which randomized patients to, it's not yet published, it was presented at the recent meeting, which randomized patients to dolutegravir versus efavirenz, clearly showing better virological outcomes with dolutegravir-based regimens. If you have a low viral load, that benefits the mother, that also reduces MTCT. And as was earlier mentioned, there is no increased risk of neural tube defects with dolutegravir. So this is outdated. All patients should be offered a dolutegravir-based regimen in pregnancy.
Okay. I think even the NACO offers the dolutegravir-based regimen, but the sentencing is a little bit like if someone does not want to take dolutegravir. So it becomes a little bit difficult to convince the patient with this thing.
Yeah, so even that has changed. That is, you don't need to discuss with patients. The guidelines are very clear. If you're pregnant, you get DTG. That is the best drug. There is no, earlier the guidelines would say you discuss neural tube defects. That's gone from the guidelines.
Yes. Okay.
So coming back to our original patient, that the male patient, so when do you want to, having started on TLD, when do you want to see the patient again, and when do you want to repeat CD4 and viral loads? Ravi sir.
First of all, the management itself is wrong. I would not have started on TLD yet. Like Harjike sir and we all mentioned, we need to know what is going on with the patient. He's got fever and diarrhea. So I wouldn't start them on TLD. But let's say there was a completely stable patient who does not have any symptoms, who's just diagnosed with a low CD4, and you're just starting them on TLD. Then I would see them after a few weeks. And depending upon how sick they are, that's how I decide. I don't just do a guideline-based approach. It is really individual-based. A lot of social issues are there. How compliant do I think the patient is going to be with the medications? Especially for people with diarrhea, this is going to be a concern. Okay, are they going to be able to take the medications? You know, is that absorption is going to be good or not? So there are a lot of issues. So many times for my patients, I ask them to see in 2 weeks, even if they are stable, just to find out, okay, how are they doing? Are they taking medications? Are they having any side effects? Are they having any support? If there's any problems, a lot of patients forget to take it. And if you don't establish that well, then you don't do very well. One of the main things I feel how well the patient does, and it's shown in some studies, is the relationship between the patient and the doctor. If that is established well, and that is usually established in the first few visits. And if you have a good relationship with the patient and the patient starts to trust you, there is so much more you can do with that patient. You have to show them empathy. You have to show them concern. And if you establish those good relationships early on, I think the patient will follow whatever you tell. But initially, if it is just a syndromic or just guideline-based approach, I think we'll be in trouble. I would rather do a more individual therapy. If the patient having symptoms, I really would not have started the patient on therapy right away.
Yes, sir, for the clarification of that only, I told that patient has cryptosporidium. That has improved. Anyway, sir, are you...
Patient has fever. Cryptosporidium should not cause fever.
But HIV per se can cause fever, sir?
No. HIV by itself will not cause fever. Fever is something else.
Okay.
So that I'm not convinced about. I would go a lot more because TB really, he could have cryptosporidium and TB somewhere else. Extrapulmonary TB, that's the most common ones. And I'm just concerned that this patient will end up with iris and Warsaw.
We'll come back to that, sir. Okay.
Yeah.
So anyway, are you worried about the CD4 count, sir? Like how CD4 count will change your prophylaxis? When are you going to come off of PCP prophylaxis in your practice? What do you do?
CD4s, I'm not doing it as frequently, but this is a new patient and very low CD4. And one of the reasons we are monitoring still CD4s is for the PCP prophylaxis. Or if you're using MAC prophylaxis, I don't do MAC prophylaxis anymore. But if you are, those are the reasons that you would want to check it. But newer guidelines are also saying if you have a viral load which is undetectable, that is good enough, not just one time, at least 2 viral loads separated out by 3 to 6 months. And I kind of going in that way in the last 1 to 2 years, I have changed practice. And if I see the viral load being suppressed, I'm not worrying about the CD4s as much. Even if the CD4s are less than 200, I'm stopping my PCP prophylaxis.
Yeah. So, Dr. Nitin, what is your practice? Viral load control with CD4 more than 100, or you wait for the CD4 to touch 350 before stopping PCP prophylaxis, like the guidelines? Sir, you have to unmute yourself. Yeah.
Sorry. So I was saying that Septran alone in a high endemic area is not only beneficial for PCP and toxoplasma, it is also beneficial for preventing other bacterial infections and malaria. So there was one trial from Africa by Dr. Hakim where, anyways, that did not, the trial was about enhanced prophylaxis, but that's besides the point that I was making. So if suppose if we are considering only PCP and toxo and IgG is negative, then if patient has a CD4 more than 100 and virally suppressed, then it should be enough to stop septal prophylaxis.
Okay. Yeah, we'll move forward.
So defining the treatment failure, this is what NACO and WHO says. So a plasma viral load of less than 1,000 copies after at least 6 months of ART. And this is for the programmatic management, as we have been and for the DHHS says it should be less than undetectable, or it should be undetectable, and failure whenever it is more than 200 after 24 weeks, it is like incomplete virological response. So, and they recommend action when the patient has a RNA levels of more than 200. So coming back to the patient, after 4 weeks of ART, he presented with swelling in bilateral cervical regions with high grade fever.
RGK sir, what do you think right now?
Well, he's smiling and laughing.
Exactly what Dr. Ravikiran said. You need to treat fever and ignore, you need to investigate fever. So something is going on now. Anything that happens after ART, the clinical dictum is that it is iris. In this case, it's certainly not cryptosporidium. It's called some other unmasking iris. Chances are high that this is going to be either TB or MAC. Cryptococcus less likely with a negative antigen that you presented earlier, but still possible. Other etiologies like lymphomas would be uncommon to present with iris, but you certainly need to image and put a needle in.
Okay, sir. So we put a needle. Dr. Nitin, can you just explain this report? What is this ultra trace call and rifampicin resistance indeterminate? If you get a report like this, what are you going to do?
Okay. So the two reports. First is about the gene expert. So the
it's ultra expert, sir. Sorry.
Yeah. So the gene expert ultra basically detects as low as 10 bacilli, and what has been seen is that with low, TB load, the accuracy of gene expert to predict rifampicin resistance becomes difficult. So with very low or with trace gene expert positivity, rifampicin resistance is written as indeterminate. So in this case, this is TB, but now here diagnosis of whether this is a drug resistant or drug sensitive TB has to be done either by culture and subsequent LPA on phenotypic DST, or as it happens multiple times where the person who did the FNAC did not send it for culture, there you will have to take the decision based on the epidemiology of drug resistance in that region.
Oh.
The second report, should I talk about the second report?
Yeah. Go ahead.
Okay. So the second report basically, I think, is showing metabolic acidosis, normal anion gap, and creatinine has risen. So what I remember is that his previous creatinine was normal. So this is basically some type of a proximal RTA, probably TDF induced. So now the thing is that, assuming that we got a culture report and we got sensitivity and this was rifampicin sensitive, you will start with a HRZE based regimen. So rifampicin has drug interactions with dolutegravir, has interactions with protease inhibitor based regimens, and has some acceptable interaction with efavirenz as well. So and also because of this Fancon is like picture, RTA like picture, TDF will not be a good idea here. So probably in this case, abacavir based regimen with based on the creatinine clearance, you can decide whether lamivudine dose needs to be modified or not. So DAL which is something that I'll do, and I'll add an extra dolutegravir for rifampicin. Rifampicin is a potent CYP inducer, so it will reduce the dolutegravir levels. So you will have to add one extra dolutegravir here.
Okay. So Ravi sir, is replacing TDF with TAF is an option in this case?
No, I really don't do that. If you really look at the studies, the difference, the absolute difference between TAF and TDF in terms of renal failure was only 1%. People, I think, are highlighting it a lot, but in reality, it is not such a big deal. There are some other reports which have said in patients with TDF renal failures, they have used TAF. Personally, I really don't like doing that. I really feel very uncomfortable with that. I would go with a alternative regimen, just like Nitin mentioned. A backward-based regimen would be a better regimen, I feel. Even a zidovudine-based regimen is probably fine, but not TAF or TDF-based regimen.
Okay. RJK, sir, will you consider this patient for a dual drug ART, like a combination of dolutegravir with lamivudine?
No, not at this point. If you look at all the trials which led to approval of the dual drug regimen in suppressed patients, they are all in stable patients who are virologically suppressed. I think the cutoff is at least 6 months. So I would definitely not do dual drug therapy in a patient who has opportunistic infections, who is also on rifampicin. I would just go with the acabacavir-based regimen and double dose dolutegravir. After the ART is, after the TB is treated, if the patient is virologically suppressed and still has renal dysfunction, I would consider it at that point, maybe 6 months down the road.
Okay.
Just one more point, Praveen, that TAF and rifampicin have interactions.
Yeah.
If you're using rifampicin, you might not be able to use TAF.
Yes. Yeah. This is again, sometimes we find that patients on rifabutin replacing rifampicin, and people think it is okay, but that will also decrease the drug levels of TAF. So yeah, that's a great point to highlight. Yeah, Haripriya, we can move on.
So, assuming we don't have further culture reports on it, how do we still act on this rifampicin resistance indeterminate, sir? Nitin sir, like mentioned, after we have cultures, we will go ahead with HRZD. Suppose we don't have cultures, or this is all the information we have regarding TB. How do you address TB? Still we treat with HRZD, or is there a different thought, RGK sir?
So I think it is very difficult to tell, but what you do in your practice, we want to hear from all the panelists. Start with Nitin, sir. Yeah. What do you do?
So sorry. Yeah. So I think Dr. Nitin mentioned you take epidemiology into context. In India, about 95-97% of TB would be rifampicin sensitive. So chances are high that HRZD would work.
Okay. So what do you do, Nitin, sir?
Yeah. So the other thing is that the patient here probably might give you some time as well. So again, in my practice here, the percentage prevalence of MDR resistance is even lower than the national average. So what we usually do is we start with HRZD. And also because this patient has just as of now TB lymphadenitis and may give you some time, so you can wait for the culture report. You start HRZD and you wait for the culture report.
Ravi, sir, you agree with the same?
Yeah, I would agree. Yeah.
Yeah. Sir, what about you said that we may consider a abacavir-based regimen along with a double dose of DTZ. So do you screen for HLA B5701 for all the patients you are considering for abacavir regimen, or you just start abacavir? Ravikiran.
I generally do it for all my affordable patients. I do it. There are a bunch of unaffordable patients that I have. In many of them, I have done it without HLA testing, and I have been fine. I have never had my hands burnt with it. The prevalence of HLA B5701 in India actually is extremely low. So we could be okay with it, but it's always better to check it, because if that one case that you get it and you get burnt, that's going to scar you for life. So it's a better way always to check for it. And that's my preference. But if you cannot, I think you would still be fine.
Yeah, just adding to that, I can't do this test in my center. For some reason, nobody in Chennai offers this test. So what I do is we take the patient's phone number and we either call them or ask them to call us every day for the first week after starting therapy. Earliest sign of symptoms, we obviously stop the drug and ask to see them back.
RGK sir again. So what about the drug modification for lamivudine? Even lamivudine is renally excreted. So
yeah, there is a paper on that. I think it was in CID, which showed that the full dose of lamivudine as a combination therapy with abacavir, dolutegravir showed equivalent virological outcomes. And so you don't the drug levels do go up, but it doesn't make a difference. Very little toxicity, equivalent virological outcomes. I just give the combo pill. There is a paper in CID on that.
Okay. So now this patient has completed 6 months of ATT with a complete improvement, clinical and radiological. So what next, sir? What are we going to do about it?
RGK, sir.
Well, doing well. So you can drop the double dose, the second dose of DTG. Your options are you can continue the same regimen the patient is on. If they're used to it, happy with it. Another potential option is to do the 2-drug. In this patient, other than the obesity, I don't think you mentioned other risk factors for coronary artery disease, correct? I don't recall. Just
Yes,
obesity, nothing else. Was
Yes,
there? Yeah. So I would just leave the patient on this regimen. Things are going well. This patient has already had a hit with TDF, so I would not reintroduce TDF.
Okay. Okay. We can move forward, sir.
Just one
So
point
this-
to add here
Yes,
is that when we stop dolutegravir, the extra dose of dolutegravir after finishing ATT, ideally supposed to wait for 2 weeks. So we continue the extra added dose of dolutegravir for another 2 weeks post completion of ATT.
Yeah. So that is one thing, sir, because that is what we even read in ACO guidelines. But the half-life of rifampicin is hardly hours. So why do you want to like continue for next 2 weeks? Like it's hardly 2 to 3 hours. So 5 half-lives will probably a 2 days, couple of days.
So, but you need to give time. What I understand is you need to give time for the induced liver enzymes.
Okay. Okay.
I think that's an overkill. I don't think that is really required. I don't know why we need to really 2 weeks. Sometimes the guidelines, I think, go overboard.
Yeah. Fine. So this patient stopped on HRJD, shifted to abacavir with dolutegravir and amlodipine regimen, doing fine. At the end of 3 years, he's in regular follow-up, but he came after like a gap of 1 year. At the end of 3 years now, he came with a plasma viral load report of 800 copies. So Ravikiran sir, what will you do if you find something like this?
Yeah, this is definitely a very hypothetical because dolutegravir has not been around in the public sector for 3 years. So it cannot be a real case for sure. But that's good. In terms of discussion, somebody's been on regimen and then viral load is high now. So first thing that you ask is their compliance. Are you really taking their medications? That's the most likely reason, right? Why are you failing? You've been fine all these years. And then you look at the trend and then you've not necessarily mentioned it, but have they been coming to me all these times? Have you been checking every 3 to 6 months or so the viral loads? Have they all been undetectable? Okay. If patient has disappeared, that also happens sometimes for 3 years, and after 3 years finally comes back 800, then I really feel they have definitely failed. But if the patient's viral load has consistently been undetectable several times, and then one time you see this, you really sit down and talk to them about their history. Are you taking the medications? And if they are taking it, then you ask them about any GI problems in the recent past, vomitings, diarrhea. So trying to find out any malabsorption. Are you taking any other drugs? Drug interactions you tend to rule out. And sometimes there's been problems in the public sector of availability of medications. There are people doing strikes on the road right now because they cannot get medications. So has that been the case? Have you missed out on medications because of whatever extra reasons? Other reasons could be any other secondary infections, TB or some other infections that could have vaccines. There's been lots of reports of after a vaccine, small blips may happen. We're trying to find out, is this truly a blip or is this truly a failure? So at this point, if I've had this and nothing else is apparent, then I would repeat this test. Usually I would repeat it at least a couple weeks later, sometimes a month later, if the patient is stable and everything else seems to be fine, I'll repeat it. And then I'll see if the viral load is still high. Okay. And I think I'll stop here.
Yeah, we have a repeat.
What will you call it, sir? A plasma viral load of 800 copies. Is it too high? Is it a low-level viremia? Is it a viral blip? What is it?
So it is less than 1,000 right now. So that is where the NACO guidelines, I think have a much higher cutoff. I don't think that's a reasonable, such a high cutoff. And we are missing out on a lot of patients by 1,000 cutoff. we have a lot of this low-level failures, low-level viremia failures, which are significant. And if you keep them on a failing regimen, you're going to completely wipe out the classes. So I feel we have to have a good enough testing. Usually, I prefer a test which has a less than 100 viral load. There are much better labs now with even viral load less than 20. Those are really good. Anything more than 100, I start getting worried about, actually. Low-level viremic failures, that means they're just starting to develop something. And if you continue it, you're going to probably lose that whole thing. And then you have to talk to them about adherence and all those other issues. If the repeat one is also high, this is no longer a blip. This is, I feel, a true thing, and we have to address it.
Okay. So we have asked about of course, it's a hypothetical case, but the patient denies any non-compliance to ART, is regularly taking it. Because of some reasons, he was not able to come for the past 1 year because of the personal reason, but he's taking the medication regularly. But he is having some gas problem, the universal problem, and he's taking some over-the-counter medication. So do you want to address that problem? So what are the common drug interactions with integrase inhibitors? Dr. Nitin.
Yeah, so after checking the adherence, probably drug-drug interactions and food-drug interactions may be the next thing to do. So dolutegravir has issues with especially cation-containing compounds. So all this over-the-counter antacids, sucralfate or whatever calcium-containing compounds, magnesium-containing compounds, they might have issues interactions. That might be one of the things. Actually, besides that, there are a lot of these Ayurvedic medicines that patients take. Like Fenjone's wort has an interaction with a lot of ARTs. Dolutegravir, like we discussed, has issues with rifampicin. So amongst the drugs, probably dolutegravir does not have as much interactions as we have with probably a boosted ART like atazanavir. But these are at least 3 or 4 interactions that, you know, it's a good idea to look for.
Okay. RJK sir, so what are the, can you just list out the drugs for our audience? What are the drugs which will interact with the antihistaminics, PPIs, H2 blockers, calcium, zinc?
Yeah, that's what you said it. Anything that's a cation, Dr. Nitin said that, you said that as well. Calcium. So many of these patients may be on calcium supplementation because of they're on TDF. So if you do that, you give the calcium at a different time of day than from when you give the ART medication. Give that in the morning, give this at night. Similarly, anything that reduces acid, make sure the patient is taking dolutegravir after a full meal, either a morning meal or a night meal. So these are the things you need to look into. True resistance in an adherent patient would be very uncommon. And you have a practical problem here. Your viral load is less than 1,000. You're going to have difficulty doing genotypic resistance if that crosses your mind. So you really have to go into absorption, interactions, and something else rather than true resistance here.
Okay, sir. Like what should be the viral load to test for a genotypic resistance? Like, can we do a deep sequencing a little bit more than what we do?
Yeah, theoretically you can. I am not aware of anyone who does that. Maybe other centers have access to that. Where I send my genotypes to, they do Sanger sequencing, which requires a viral load of at least 1,000.
Okay. So basically here it is a little bit difficult to really know whether this is really a drug interactions or non-compliance, but looks like this regimen is failing. So how do you want to proceed next, Ravi sir?
So at this point, really, we cannot do a genotype testing. I wish we do some of those deep gene sequencing. I think we need that, but I think we are a little bit away. So at this point, we are failing. So what are we failing? So most likely failure would be the NRTI, lamivudine or the tenofovir, either one of them. Okay, or abacavir. Sorry, we changed it to abacavir. I forgot. So one of those, which one it is, hard to know, but those are the most likely. Dolutegravir resistance is extremely rare. It really requires a lot of non-adherence. So I'm not sure if that is the issue. So at this point, if we have to change to something, I would let go of the abacavir lamivudine. I would continue dolutegravir and add a PI. And my preference for PI at this point would be an atazanavir based regimen. So atazanavir plus dolutegravir is something that I would consider.
Okay. Dr. Nitin, what will you do like in this case?
No, so again, like I said, that developing resistance on an integrase inhibitor based regimen is something that I'll not be very happily accepting at this point of time. But if suppose in the situation you tell me now, this is definitely drug-related failure, a patient is on dolutegravir, abacavir, lamivudine based regimen, and the patient has failed, and we have ruled out all the other causes. In that case, if I have to change the regimen, probably again here we have better experience with changing from NNRTIs to either PI, the trial, the earnest trial evidence we have without resistance testings, or the Nadia trial for to dolutegravir from NNRTI. But from dolutegravir to other PI, the evidence is a little less. But probably in this case, what I would do is that I will change one of the NRTI backbones. I'll continue lamivudine. I'll change abacavir probably to zidovudine, because L174V is what I think abacavir is resistant to. It might share a little bit with TDF, plus there are issues with Fanconi's. So zidovudine may be a good idea. So zidovudine, lamivudine, and dolutegravir. Either there are two options here. Either I'll increase the dolutegravir dose and see, or when I don't have a resistance testing option, or I'll change it to darunavir, ritonavir based regimen.
So double dose of dolutegravir with darunavir, ritonavir with a NRTI backbone. That's what you're saying, sir?
No. I'm saying that two NRTIs. That means one lamivudine, and instead of abacavir, zidovudine, because I would not like to start TDF here. And instead of a PI, instead of a single dose dolutegravir, either double dose dolutegravir or darunavir, ritonavir based regimen.
RJK, sir.
No, I would not change the regimen. This is not drug resistance. This is something else. This is a malabsorption issue. This is an adherence issue. I would just follow the patient closely, go over all the medications he's on. What else is that patient on? You really don't want to diagnose INSTI resistance without confirming that on a test. This patient's CD4 is good. I would just do repeated CD4s and viral loads. Once that viral load climbs to above 1,000, then I would look for resistance testing. And for all you know, it might come back as pan sensitive. There's an adherence issue. Patients don't like to say that they are not taking drugs. So, and this patient is also obese. Remember, are we underdosing his drugs? All those things I would go through. I would not change an INSTI-based regimen without proof that there is resistance.
Okay, sir. So very interesting point of view. So we have repeated the viral load again, and it did go above 1,000. So how are you going to approach now? Like, will you
if
go
CD4s are good, repeat in 3 months. See, if your CD4 is good and your patient is following up with you, and you just wait and watch, repeat viral loads frequently. There is no emergency to change the regimen when the viremia is so low. You need to make a diagnosis. What is the problem rather than changing in a hurry?
Sir, Dr. Ravikiran has mentioned that if you continue with the regimen with integrase resistance, probably you might lose the whole class of integrases. Like dolutegravir is the best anyway, but you want to still wait.
Yeah, I would, because in the end, I've gone through this scenario many times, not with INSTIs, but with NNRTI-based regimen. And you do a genotype and it comes back as pan-sensitive. You can counsel the patients hundreds of times, but there's some fight with their spouse, and for that reason, they didn't take their medicine. A lot of the things patients don't like to tell you. So don't get into INSTI resistance with such a low viral load till you are dead sure you've proven that with a genotypic resistance. Just observe the patient. CD4 is good. Follow closely. Repeat viral loads. Do the resistance testing when it's more than 1,000 and go from there.
Yeah. So this patient again came to us, like this is a hypothetical case, obviously. Yeah, go ahead, Haripriya. Yeah.
So these are all what we already discussed, most of them.
Yeah. So Dr. Nitin, you have mentioned that you will still have that INSTI, like NRTA backbone. Why do you want to keep the lamivudine there when the patient is failing already?
No, so again, I'll just clarify again. I agree with what Dr. Rajike was saying, is that making a diagnosis of in-stage resistance is something that we should, be very, very confident with, that we, this is definitely that the patient is failing the regimen. But again, my answer was based on a hypothetical scenario where we know that the patient has definitely failed and we have ruled out all other causes.
Okay, so I'm asking because that is what even the guidelines says. So you keep the NRTA backbone intact, even though there is.
So so again, so the most that, like I said, the most data. So I'll go with the Earnest trial first. So the Earnest trial, I think in 2014, it reported that if you, when you compare two regimens of a patient who's failing on an NRTI-based regimen, there are two options. Either you keep the NRTI backbone, or you add, in that trial, they used dolutegravir plus a protease inhibitor. So between the two regimens, there was no significant difference. So an NRTI backbone is okay. That is the first thing that came from that trial. The second thing that came from the trial was that in patients who had no active NRTIs, that there was a reanalysis done and they published it in 2017, that same Earnest trial patients, that even if there are no NRTI active on genotypic resistance testing, these patients still respond to an NRTI backbone. So that was the first trial. And second, from the Nadia trial, what they got out was that they found out similar results when you change to a from an NNRTI to an integrase-based inhibitor regimen. So the crux that I understood was that even if your genotype, if there is genotypic resistance or the patient is failing an NRTI backbone-based regimen, it is still worthwhile to continue your NRTI backbone. So in both the trials, in patients where there was no predicted sensitivity to NRTI, in those patients, there was 90% achievement of negative viral load when you add either a dolutegravir or a darunavir-based regimen. So in such a patient where your dolutegravir is failing, if this is just extrapolation, you can probably, if suppose there is development of a dolutegravir-based regimen, the 148 series, then you can probably change to a darunavir-based regimen and continue that NRTI backbone.
Okay, so now that you have mentioned about Nadia trial, I had very tough time understanding the study, because 50% of the patients who are on TLE regimen, they had K65R, which is something which gives resistance to both lamivudine and tenofovir. And despite of that, when they switch it to TLD, from TLE to TLD, they have done better than ZLD. So what is the explanation for that, sir? Is it like dolutegravir monotherapy we are giving, which is effective for 92 weeks, which is the follow-up?
So the crux of what both the trials that was done by the same group of authors is that NRTI genotypic resistance may not predict clinical response, because in those who had 3 active drugs, in fact, the efficacy in both the trials actually was lesser than those with no active NRTIs. The explanation that they have given is probably because if you have that 184V mutation for lamivudine, it makes you hypersusceptible to other drugs. That was the initial explanation. But now again, the Nadia trial is showing that even if you continue the TDI-based backbone, if you just change the other drug, just NNRTI to dolutegravir, that is enough to improve the viral response.
Okay, so previously there was a trial called DOME mono trial, where people have actually tried to give a dolutegravir monotherapy, and all the people, they have done well till the end of 2 years. But after 2 years, they saw some of the patients are actually like 7 out of 100, they develop dolutegravir resistance. So do you think that this NRTI backbone is not effective and dolutegravir, because it's such a good drug, probably it is still active till the follow-up in Nadia trial, and should we be taking that results very seriously, or is there any gray area in this?
The thing is that, again, this is just 96-week results. What you're saying is right, that whether this is effectively a dolutegravir monotherapy, and over 2 years, 3 years time, we will start seeing dolutegravir resistance. As of now, in this trial, there weren't a lot of INSTI resistance on those patients who were kept on NRTI backbones, which were presumably not active based on genotypic susceptibility.
Okay, so we'll move forward. Haripriya, let's go. Yeah, so basically this is of course a hypothetical case, and I said that the viral load did go above 1,000 and we did get this genotypic resistance. So Ravikiran sir, what are your comments here? Like, what do you see?
See, I was predicting this earlier, so I wanted to change it earlier. So definitely, that's why I would get away from those things. And I think PI and integrase inhibitors is what we need. Maybe double dose dolutegravir with the PI. And PIs, he's never been exposed to PI. So I would start off with atazanavir. I see atazanavir, lopinavir, and darunavir as 3 levels. So I don't want to go to darunavir yet. I would rather do atazanavir. I really like atazanavir. I think it's a really good drug. As long as you don't worry about the bilirubin too much and get too excited about it. But that's what I would prefer.
Sir, one of the problem with atazanavir again, with especially when we are combining it with tenofovir is CNS penetration. So, have you ever seen a patient with a CNS escape developing neurological symptoms on atazanavir in your practice?
No, CNS penetration, we don't need it for all patients. The CNS escape patients, I have definitely a few CNS escape patients, but it was not because they were on atazanavir. Okay, my CNS escape patients have been really big on efavirenz-based regimens, or the older regimens, the nevirapine-based regimens. With dolutegravir, I really don't see much of CNS escape actually. With atazanavir also, I don't really see much of that. I think that's such a small population that we see. I've had several hundred atazanavir patients now, and I've not had one case of failure of CNS escape with that.
Okay. RJK sir, like, what are your comments on this genotypic resistance testing?
So is this a true genotype or something
No,
you
sir,
made up for the
made up.
presentation?
Yeah, we made it up, sir. Everything in this case is made up. Yeah, we just wanted to discuss every aspect.
Yeah, so in general, I agree with what Dr. Ravikiran said. You introduce classes of drugs which the patient has not seen before, but you retain the backbone. If this patient is on lamivudine, you retain it to preserve because the mutation actually increases your viral fitness. Reduces your viral fitness. So what he said is reasonable. PI. Continue with dolutegravir. Don't stop that. Continue with lamivudine. If you are on abacavir, right? At this point, this patient was on, correct?
Yes, sir.
Yes, sir.
Yeah, sure. Continue that as well, and hopefully you will suppress. Personally, I'm more comfortable with darunavir, ritonavir, but any PI is fine. The principle is expose the patient to new classes.
So, what do you use, darunavir, ritonavir, the BD or OD 800 OD?
If you're using a PI for purposes of second-line therapy, you always give twice daily doses. For naive patients, the once daily dosage is appropriate.
We'll go ahead.
So these are the few of the mutations and listed mutations and how to interpret them. So we are coming to almost the end of the session. So we will. I think we talked a little on dual drug ART. So we will deal with each of these quickly. So RJK sir, what is your thought on long-acting ART?
Yeah, it's a wonderful new intervention. It is really going to revolutionize how we treat non-adherent patients. Now, the trials are done in adherent patients, whether it's Gemini or Tango, suppressed patients doing well. But there was just a very recent publication in I think it was CID, which looked at non-adherent patients, patients who are doing IV drugs, they weren't showing up in clinic. For those patients, it's going to be a wonderful new intervention. You just have to find them and give them a shot once every 2 months. So really looking forward to that coming to our country.
Okay.
Praveen sir, what are your thoughts about intermittent? Recently, there is an article published where 4 days on and 3 days off, and it is shown to be like equally good compared to the daily treatment. So
I'm not a big fan of intermittent therapies. Once you start going intermittent, it's hard to remember which days to take, which days you don't take. I mean, people hardly have a good memory of taking it every day. And then when you split up, I really don't like that. Even the long-acting ART that Dr. RGK mentioned, it is good, in some of those non-adherent patients. But in the trials, right, in non-adherent patients, people went out and sought those people. They go under the bridge, under the bushes, and really look for those people. That's how aggressive they are. Who's going to do that in India? Who's going to find those non-adherent patients? So my concern is for especially those non-compliant patients on long actings, and if they fail it, we're really losing a good drug. I don't want to lose integrase inhibitors. So that's my concern with those people. With adherent people, I think it's great, but non-adherent, I have a lot more concern.
yeah, so that particular trial have excluded all the patients who are non-adherent basically. So I think that is a difficulty in real world scenarios. Dr. Nitin, what are you keeping any patients on pre-exposure prophylaxis in your practice? Are you prescribing?
Yeah, so because primarily most of our patients are not able to afford ART, it becomes a big problem. This is absolutely a great idea. WHO has come up with guidelines, but NACO has still not come up with pre-exposure guidelines. I'm looking forward to its inclusion so that we can use the current machinery to give pre-exposure prophylaxis to all the patients. The on-demand pre-exposure prophylaxis especially for MSM patients and some transgender patients would be a really good idea. But yeah, for my patients, because predominantly for affordability issues, I'm not able to prescribe.
Okay. RJK sir, I want you to take our last two questions. What about the drugs which are available for heavily treated patients, not in India, across the world? And what about the HIV cure? Sometimes patients come to us in OPD and they say that there is a patient who is cured of HIV, cure me also. So how do you counsel those patients?
Yeah, there are new drugs coming out. For instance, this attachment inhibitor, ibalizumab, etc. But obviously a long way off from India. So at this point, theoretical for the Indian scenario. HIV cure, yes, a lot of patients read about these patients, but you can tell them if you want to get cured of HIV, first you develop a blood cancer, then you get cured of the blood cancer, and in that process, if you survive that, you'll get cured of your HIV, which is exactly how these Berlin patients, London patients, etc., got better. There is a HIV gene splicing technology, but it's not for cure. It reduced viral loads. All these patients rebounded later. So if you tell them that, they won't ask that question again.
Okay. So I think there is one last question for all the panelists. Dr. Ravikiran, how will you compare having HIV or having diabetes per patient? What is good for the patient?
Yeah, I tell my patients, yesterday I had a new HIV patient, new diagnosis, and I gave them exactly this. I tell them HIV is more like diabetes now, and even cancers. Dr. RGK was mentioning about people getting cancer, and I told them, if I have a choice between getting HIV or cancer, I would get HIV any day. I know how to deal with HIV, and the long-term success rates, life expectancies is great with HIV. In some of my patients who are diabetics, and I worry a lot more actually these days about diabetes than HIV. If you are taking your medications correctly, HIV is, I feel, preferable than diabetes. Diabetes have a lot more multi-system effects, and it has a lot more restrictions in terms of food and what you can do in life. Otherwise, I feel HIV is much better. I would prefer HIV. So, and sometimes we have to actually with our mouth tell that to a patient that I would rather get HIV. When you say those things to the patient, they really start opening up to you. They're like, oh, this guy is really cool with HIV.
Okay.
That is what Dr. Praveen does a lot in OPD these days. So
Nitin sir, what do you prefer your patient to have HIV or diabetes?
No, absolutely, I agree with what Dr. Ravikiran said. And
RGK,
the only, sorry.
It's okay. Continue, sir.
You're preaching to the choir. These panelists will only say HIV. So you should ask diabetologists that.
Yeah.
So that is really great to hear. Like there is a lot of stigma attached around HIV, but now we know that if viral load is controlled, it is almost like a non-communicable disease. So that is really what I was expecting. Thanks a lot. So we had a wonderful session with our panelists. And we will wrap it up. There are some questions posted. I will ask one or two to the panelists. So I think most of the questions. So one interesting question is, what about the patient with probably a CLD, like a CLD with liver failure? So which ART regimen will you choose in patients with a DILI or liver injury?
Ravi sir, you can take that.
That's a hard one. It depends upon where is the patient, right? So is that a patient just with, is a patient treatment experienced, treatment naive? How bad is the liver injury? What is the MELD scores? So Child-Pugh scores. So with severe liver problems, dolutegravir is really not a good idea. Neither is darunavir as a good idea. Atazanavir also not a good idea. So what are we really left with? We're really struggling at that point. If you could use efavirenz NRTI based regimens, you could use lopinavir. In really advanced liver failure, the treatment options are very limited.
Okay, sir. I think most of the other questions we have like discussed in the discussion itself. So I'd like to ask Mr. Balaji to give a closing remark at the end of the session. And we are very glad that we had this discussion today. It was a joy to have this webinar.
Thank you, Doctor. This is Balaji from MK Pharmaceuticals, in charge of the Global HIV/AIDS initiatives. It's one thing to read about these trials and from the books, but it's another thing to be listening to such experts like this distinguished panel. So I thank each one of you, Dr. RGK, Dr. Ravikiran, Dr. Nitin, Dr. Haripriya, and Dr. Praveen for sparing your time on this valuable Independence Eve Saturday to share your thoughts and views about what exactly is going on when you are dealing with your patients on a day-to-day basis, and your insights into the future of HIV therapy. A very interesting session, and we at MK Pharmaceuticals are quite very happy to have provided this platform for this scientific discussion. We would continue to be engaged with each one of you in the months and years to come in furthering this science. And as we look into new drug therapies, we will be looking forward to more such scientific sessions to open up our minds and expand our presence in this field. Thank you all very much, and have a nice evening. Good day to all of you, sir.
Thank you, Mr. Balaji.
Thank you.
Thank you. Thank you.
Thanks a lot, sir. Yeah.
Thank you, sir.